Okay, so the investigations, I absolutely found this challenging, especially the stuff that wasn't our specialty. And in the exam stress, the heat of the moment, yeah, missing that obvious thing um, that someone was saying, I think it's just such a really big fear. I think there is this useful rule, the 90-10 rule, like 90% of your outcomes will be given with 10% of your knowledge. I do think this exam favors that. Like often, like there's a few things that are absolutely fair game, but other things where if we're not reading it a lot, often the problem will be obvious. And I'm definitely going to go through strategies, patterns, a couple of hacks, and just this regular practice. And again, I'll give you guys this video unedited as a link, so you'll be able to go through everything again and see everything. And so hopefully that will get you to that point. And we'll also try to get some certain language structure again, trying not to miss that obvious thing. If something looks abnormal, just say, "Hey, look, this looks abnormal." If you want to do relevant negatives, to show your knowledge, I think it's really useful. It just shows this exam is subjective, and the ability for you to show some knowledge and say, "Look, I'd expect to see that or that or that," knowing the package of things you might see in heart failure or a young person with shortness of breath or someone with medical disease. I think it's, again, really useful to have this kind of language. It looks like an absence of various language structures, again, really useful. So what investigations do you look at commonly? So these are going to be the ones that you need to know pretty well. So ABGs, ECGs, and chest X-rays. So yeah, with the absolutely with ABGs, I feel like that is something that we should know pretty well. We look at it all the time. We take gases. We might not know it in some epic sense, like some of the ICU doctors that I've known, but we need to know at a higher level than most other doctors. ECGs we need to know reasonably well. We often are looking at a rhythm strip day in, day out. Obviously not as well as a cardiologist, but absolutely. And that's why we had our ECG session a couple of weeks ago. And then chest X-rays. Again, we look at these frequently enough that we will hopefully be able to identify obvious abnormalities. The things that we have to read at a non-specialist level, like I'm not a respiratory physician. I see respiratory function tests occasionally, and they've always got a report on there. So, with that in mind, I know we'll go through basically what we have to do to read that. MRIs and CTs, again, it's a specialist area. There'll be glaring abnormalities. Rotem and TEG, we kind of have to know, but again, there's lots of patterns and there's a whole formula for how these need to be done. So we'll go through TEG in this session. And there's some really great resources for learning Rotem, such as the Obsgynae Crit Care website. Transthoracic echo, we already talked about. The fact that you're not going to be reading an ultrasound, the sonographic image. You're simply going to be looking at the report and seeing it might not have a conclusion, but you should be able to tell what a valve area is, ejection fraction is, for example. And again, CTGs, really, there's less to know there. So you can learn a little bit of information, that 10%, and get so much of the information out, or you can get so much information out to your examiner just by knowing a little bit of information. So let's get started. So I thought the first thing we do, just crack on with AB, arterial blood gases. Okay, so I'm just going to go through kind of the basics of it, the structure that we have, the approach, some definitions and easy calculations that we can use. In the context, so it's often in the Viva. I think the important thing is to rapidly state the obvious abnormality, or work through it systematically. Like if you already can see it's a respiratory acidosis, the pH is down, the CO2 is up, you can say, look, this is obvious abnormality of respiratory acidosis. In more detail, there's an acidemia. This is, CO2 is elevated. There's the compensation, blah, blah, blah. And this is what's expected. And then try to give a complete answer, ideally without prompts. So, the fact that you can work through the whole thing without the examiner saying, oh, yeah, how about this, how about this, how about this? Like if you've got an ABG with this many things on it, which we'll go through in when I just flash up some real exam by the stems, the fact that you can just go through each of those and look at it systematically and comment on each value, I think is really important in this exam. It's the normal ranges that we'll use, greater than 70 is considered safe, but obviously it depends, and you'll check the AA gradient after that. pH, 7.35 to 7.45, 35 to 45 CO2, 22 to 26 for bicarb, anion gaps 8 to 16, and base excess is -2 to +2. And I always just take the middle number when I'm calculating things. If I'm looking at compensation and adequacy, I'm just taking 40. I'm not trying to get too complicated. I'm using 24. I'm using 12 fine and anion gap for, just the normal range. So don't get too fussed with the ranges there. The method, again, I just use oxygenation first. So, I gave out the pre-reading stuff. So hopefully, when we go through the exercise, everyone goes through this kind of method. But if you have another method that works, go for it. But I encourage everyone to go to oxygen first because that is, what's going to kill the patient, first of all. pH, and whether it's an acidemia or alkalemia. And then, what is the cause? Is it respiratory acidosis or metabolic acidosis? And find out what the process is. If it is acidemic, check the anion gap, and then you can check for compensation afterwards. And there's a few easy rules for that as well. So I never know exactly where people's levels are. So I thought I'd just quickly go through this. So yeah, we've already talked about using 7.4 and 24 for the calculations for PA, CO2, and bicarb. Oxygenation, state the PaO2, just absolutely state it. Is it safe? Hypoxemic can be kind of a relative term in some settings. Is it safe? Are they hypoxemic? And is it severe? If someone's got a PO2 of 50, there's a problem and you should state it with that kind of severity. Why do you not say hypoxia? Yeah, I mean, the examiners get this wrong all the time, so I'm not too fussed, I guess. But hypoxia is at the tissue level, hypoxemia is in the blood. So I think it's a wrong thing to say it's hypoxemic, but I'm sure the examiners get that wrong as well. Calculating the AA gradient. Now, this is really straightforward. Just look at the FiO2 and multiply it by 5. That's your quick solution. If you want to do it properly, you have to use the alveolar gas equation and think back to your primary exam stuff. But I've really never had to think about this in this way. And then you don't have a calculator with you. You're not expected to do maths for this exam. So FiO2 times 5 seems very reasonable. So FiO2 30% times 5, 150 you'd expect. So if it's give or take a few millimeters mercury difference, it's fine. But if it's grossly different, then there is a gradient. So normal difference, they've got this age. So if it's less than age over 4 plus 4, that's roughly so it's funny enough, it's the pediatric tube sizing, but that's roughly how much leeway you can have when it comes to the AA gradient. So imagine the older the patient, imagine the patient's 100 years old, divided by 4, 25 plus 4, so that's around 30. So if you've got about a 30 gap, as when you're really old, and much less when you're young, that's what you'd expect. And what does this gradient mean? So if you have an AA gradient, it means there's some level of shunt or mismatch between the pulmonary capillary and the systemic arterial oxygenation. So likely shunt, some level of VQ mismatch or diffusion abnormality. Again, state the pH. Is it acidemic or alkalemic? Don't say alkalosis or acidosis yet. Most examiners are really up with, pretty anal about this, especially in part 1. State if it's severe. So if it's a pH of 6.9 or 7, that's a real massive problem and worth stating. That's easy, but the next thing is, what is the cause? Is it respiratory metabolic? So if it's metabolic acidosis, your pH is low, but your bicarb is low, respiratory pH is low, CO2 is high. If it's both of these, then it's mixed acidosis. It might be inadequate compensation as well. Likewise, with alkalosis, it's really just the reverse. pH greater than 7.45, bicarb greater than 26 for metabolic stuff, and less than 35 over PCO2 for respiratory alkalosis. And again, you can have a mixed picture as well. So I think if you get to this point, you've probably passed that part of it. I think the compensation, I think it's nice to have a bit of an idea of this. And I think of 4 numbers, 1, 4, 2, 5. If it's respiratory acidosis, for every, you expect the bicarb to rise a certain amount for when the CO2 rises. And pretty much if the CO2, for every 10 millimeters mercury that the CO2 rises, your bicarb will rise 1. If it's chronic, for every 10, it'll be 4. So for example, pH is acidemic, PCO2 is 60, expected bicarb is 24 plus 2 because 60 is 2 lots of 10 above 40, which is normal. And then 24 plus 2 is 26. And we'll go through a couple of exercises where we do this. If this was chronic, it would be 20. So it would be, 2 lots of 10 above 40 times by 4. So it'd be 8. So 24 plus 8 expected would be 32. Does that make sense to everyone? Yep, good to know. Again, it's always hard to know where to pitch this, but please jump in if it's not obvious. If it's a respiratory alkalosis, again, expect the HCO3, the bicarb, to decrease. And now my numbers are 2 and 5 instead of 1 and 4. So for acute things, it's for every 10, it moves down 2. For chronic, for every 10, it moves down 5. So let's take a similar picture where the PCO2 is 1 lot of 10 below 40. Expected acutely is to move down 2. So 22 would be expected. Chronically be 5. 24 take away 5 is 19. So for some reason, 1425 just makes sense to me. I can remember that. And that's how we calculate compensation for respiratory acidosis and alkalosis. Again, jump in with any questions at this stage. I feel like the compensation for metabolic disorders is a little bit more tricky because now, again, in the exam, you're not really expected to be able to do mathematics in your head, and multiplying these numbers just can be pretty tricky. So, expected is 1.5 times the bicarb plus 8 for metabolic acidosis, alkalosis 0.7. I don't think anyone's going to expect you to do this. So I think most people would expect you to know. So here's some examples. But most people would expect you to know that the last 2 digits are roughly what the expected PaCO2 would be. So I don't know if anyone's ever told you this hack, but between a pH range of 7.1 to 7.6, the last 2 digits of PaCO2 is your expected CO2 compensation or your respiratory compensation for metabolic disorders. Interesting point. So maximum compensation takes about 12 to 24 hours. The last 2 digits of the pH, so between 7.1 and 7.6, and compensation is limited to PCO2 at about 10 millimeters mercury. Also, PCO2 rises, but it's also variable. The maximum PaCO2 is about 55 to 60. And just remember, in a sick patient, hyperventilation, to compensate for the alkalosis, this might fail because of pain and anxiety and other factors. So, there's definite limits to this, but it's probably better to do this and get just a rough idea and be able to say, oh, this looks like approximately the right compensation or inadequate compensation, or it's overcompensated, like there's another picture happening, instead of using these formulas, which I don't think I can just kind of imagine that you'd be expected to know in the broad scheme of things. I thought we'd, just like everything that we do here in these courses, let's go through some exercises. Oh, sorry. If you've got a metabolic acidosis, you've got to calculate the anion gap. Again, the simplest way is sodium, take away chloride, take away bicarb. I haven't put lactate and potassium in there. I think this is pretty much where you need potassium in there. So the normal is about 12. If it's wide, what's the cause? It's going to be dual: diabetic ketoacidosis, uremia, lactic acidosis, and ethanol, and that includes all the ethanols and methanols and ethylene glycols. So just toxins, really. DULE. If it's normal, then you've got GRAN, GI causes, renal tubular acidosis, drugs like azidolamide, SNCs, and chloride. So normal serum, as we all know, that can cause a hypochloremic metabolic acidosis. Base excess can be really useful to confirm there's a metabolic component. So, you don't have to look at anything else in this picture. If you have a base excess that's negative, then you have a problem. So it is the dose of acid or alkali to return in vitro blood to normal pH at 37 degrees and a PCO2 of 40 millimeters mercury, and it's already corrected. Again, very part 1 primary exam stuff, but if there's a metabolic component, you will know that because of the base excess. Life in the Fast Lane has this amazing table. Obviously, there's a lot of detail in there, and I've given this out just in the handouts, I believe. But just really good to have a snapshot of where we are at with this. Yeah, let's do some cases. Hey, I'm just gonna go around the room. Damon, you get 2 because this one might be a bit straightforward. I want you just to talk through this one.
Okay, so oxygenation is normal. There's a borderline mild acidemia. Um, the CO2 is normal. The bicarb is normal, and the basic cis is normal.
Yeah, Bill. Because
So,
it's 7.35, I reckon don't even say mild acidemia. It's just normal. Like
okay.
there's no problems here. Yep. And oh, look, I've said AA gradient present. Um, 6 liters, what do you expect your FiO2 at 6 liters to be? It's probably, around the 25, 30, 40 mark, but yeah, I'm not too fussed about that in this situation. How about this one?
So oxygenation here is normal. Um, what would the AA gradient be? Probably not actually, is it?
Yeah, you can imagine that that's pretty normal. It's probably 30 from a nasal prongs,
Yeah,
FI 30. So
yeah,
30 times 5, 150. Let's just call it normal.
cool. There's an acidemia,
Mhm.
pH is 7.3. Um, the CO2 is up, so there's a respiratory cause, and the bicarbon basic excess are both normal.
Now, what do you think about the compensation here?
Well, I don't do these things well on the spot there.
No, no, that's totally all right. Now, um, actually, everyone just take 10, 20 seconds to write down how they think of compensation in this, just because, we might as well extend everyone. I think everyone can get to this point, and that compensation, once we drill this, it will be so much easier. If everyone's got in their handouts the rules, or if anyone wants me just to go back to the rules, that's fine as well. But for every 10 above 40, you'll either move 1 or 4. Does anyone want to jump in and just tell me what they've come up with for compensation?
No, I could jump in. So
Yeah, go
for
for it.
respiratory acidosis, it looks like the expected bicarb would be 26 acutely. So I think this is acute. If it was chronic, I'd expect it to be 32.
Yeah, that's right. And how did you do that?
So that was with the one to 4 for respiratory acidosis. So PaCO2 is 62. So it's 2 lots of 10 above normal. So it's either going to be 1 times 2 or 4 times 2 added to the baseline bicarb of 24.
Yeah, exactly. So 60 is 2 lots of 10 above 40. Again, this is annoying maths. Like in the heat of the moment in the exam, I can't imagine it's that easy unless you've practiced it a bit. But I guess I just want you to have a sense where you can say some intelligent things and hopefully get somewhere close to the answer. Again, I can't imagine it being something that they really need you to know in a great detail. But if you know this and we practice this, maybe you get to that point where you can extend yourself and say some useful things. Good. Let's try this next one. Can you talk me through this case?
So this patient has hypoxemia and an acidemia, and I would say it's just partially compensated.
Yeah. And as soon as you say, look at the oxygen, the very next thing,
Yeah.
so I'm happy you said, look, this looks hypoxemic. This is a PO2 is 70. That's not great. The very next thing is there an AA gradient? Because now I can extract more information. So what do you think?
Given the oxygen 2 liters,
Yeah. What's the expected? What's the expected?
that would be 100. Then when you
Yeah,
take that by, I know.
let's say your nasal prong oxygen gives you an FiO2 of about 30%. What's your expected?
Then times 5, that would be 150.
Great. So, do you have an AA gradient?
The gradient.
And what we mean by that, Danielle, so if you go 30 times 5 is 150, I expect it to be 150. 70 is far below that. That's a massive AA gradient. That's a real
That's
problem.
80, and that's much more than you would expect with her age.
Exactly. Perfect. So,
Mhm.
so as soon as you see that number, I don't even really look at the age plus over 4+4. I first of all just go, look, is there a massive gradient? And this is a massive gradient. I never need to look at this. The maximum gradient that's expected is about 30, and that's when you're 100 years old. It's probably more than that, to be honest. But as soon as it's more than 30,
So 80 is definitely beyond.
great. So I want you to say that that's the first thing you say, because that's so severe that there's a problem. And then you might offer, look, in this patient with COPD, there might be pre-existing lung disease that's causing this, that you can see that could be the picture here. Do you think this is, I think you mentioned it's partially compensated. Another word could be acute on chronic. And you can imagine, if I didn't tell you anything about these numbers, you could have seen the patient is on morphine, PCA, and has COPD. So they've got a chronic process with an acute process. So you could probably figure that out.
So then it's still within the expected range.
Yeah, exactly. I think I've got my numbers a bit wrong here because I put 60 there, which I might just correct right now. But there's you can see a plausible acute on chronic picture here. The takeaway from that, okay, so as soon as you see that AA gradient, please comment on it. It's a big deal. Acid, ABGs aren't just about the acid-base stuff. It's really, really, the oxygen is probably the most important thing we look at. That's the first thing that's going to kill the patient. Okay, next one.
Lahira, sorry, what was this calculation? 24 plus 1?
Yeah,
plus
so
4.
Imagine the PaCO2 is now 10 above normal.
Yeah.
And so I've just put some numbers here, but let's say there was already an existing chronic picture. So that's, 4 times 1. And then if there's any kind of acute picture on top of that, I've just put 1 times 1. I put some fake numbers here just to show, I haven't got this actual ABG, but for the purpose of the exercise of a patient with a chronic respiratory problem, COPD, and a new respiratory problem, PCA morphine, this doesn't fit just acute or just chronic. Hey, does that make sense?
Yeah, so the chronic was because of the COPD. This is plus 4 that you added is because the patient already has COPD.
Yeah,
so
exactly.
That's why you added this 4. Okay, all right. And the plus 1 that you added is because the CO2 is 10 above the normal range.
Exactly. It would not exactly be these numbers, but yeah, again, for the principles of just trying to show you that a clinical picture plus a blood gas gives you a result there.
Sorry, Eric, if you've got an acute on chronic, can you just add the difference of the acute and the chronic?
Okay.
You know what I mean? 'Cause you've only got a PaCO2 difference of 10 or 11.
Mm-hmm.
So you're saying it's 4 plus 1 because it's both acute and chronic, but it's the same CO2 difference. So you don't have to compare what it was at baseline.
Yeah, absolutely. And we don't have a baseline reading. This is completely just an example. Alex, you're absolutely right. This would not be a PaCO2 51. It'll be some other level, I assume above 51, I think, because there'll be an extra amount on top of that. So yeah, you're right that the numbers aren't perfect there.
Okay, all right, that's fair enough.
No, but definitely that's absolutely worthwhile addressing. I'm absolutely making these particular numbers up for the purposes of easily calculating something for a principle, but definitely not real numbers. The more important thing is the history context, and that we get to a level of saying something reasonable. Next person along. Do you want to have a go at this one?
So can you hear me? So
Yeah.
Looking at the oxygenation, they're on 100% FiO2. So I would expect their AO2 to be roughly 500. So it's a little bit low, suggestive of an increased AA gradient. Well, quite low.
Mm-hmm.
Their pH is, so they're alkalemic. They've got a low CO2, sort of consistent with maybe being hyperventilated, so a respiratory cause of the alkalosis. and their bicarbonate is slightly low, which I suppose is probably some acute compensation for the hyperventilation from a metabolic perspective. The base excess is normal, so there's no underlying metabolic, severe metabolic acidosis or alkalosis underlying that. It's primarily, I think, maybe a respiratory disturbance with some minor metabolic compensation.
Yeah, sounds good. Shows acute compensation. So, 2 lots of 10 below 40 is a PaCO2. So 2 times 2 times 2 is 4. 24 take away 4 is about 20. That's about right. That's good. 70-year-old emergency with small bowel obstruction. Next person along.
So we've got a safe oxygenation. Can't really comment on the gradient because I don't know what oxygen is on. I guess if he was on room air, then expect a PaO2 of 100, so that would be a wide gradient.
Doesn't
really make sense.
The gradient doesn't go the other way. Yep. So you can
yeah, it doesn't make sense.
But you're right.
So actually, I have to assume he's on some amount of supplemental oxygen. Not sure how much. He is severely acidemic with the respiratory alkalemia. It's a large metabolic component, so metabolic acidosis. It looks like we've hopefully got a sodium and a chloride suggesting that we should be calculating the anion gap. Yep. So the anion gap is going to be 140 minus 110 minus 9.
I'll give it to you here. It's about 21.
Thanks. 21. So normal would be around 12, so that he does have a raised anion gap. So, I've got a different mnemonic from memory, but I'm thinking of hagmads, ketones, urea, lactate, and other toxins.
And
small bowel obstruction.
Yeah, what's the most likely?
Probably lactic acidosis would be the most likely.
Right. A lot of the times you don't need a mnemonic for something. I think most of us have seen a small bowel obstruction or a massive hemorrhage or some other kind of ischemic type event. That's lactic acidosis. Who cares about the mnemonic? You can't remember it. It's you already know it. Your expected PaCO2. So it's too far beyond the compensatory range. So you expect it to be 21.5. This patient's not compensating that well. So you could almost, by the PaCO2 already being 30, you think, oh, this patient is hypoventilating for what the expected pH should be. So yeah, even without using your calculator for the numbers, you can still make that potential thing. But I like that as soon as you see metabolic acidosis, you calculate the anion gap. If it's raised, you make a prediction for what it is. And normally on the blood gas reading, you'd probably get a lactate reading as well. But again, this is for this exercise. Very good. What do you think of this one?
Yep. So he's intubated, FiO2 100. So at the moment, oxygenation is safe, but there's a large AA gradient. He's got severe acidemia with his pH of 7. And it looks to be a metabolic acidosis with incomplete respiratory. I don't know, maybe it's not. Metabolic acidosis. With incomplete compensation, respiratory compensation.
Yeah, that's right. It's hypoxemia. It's a really massive AA gradient, like you said. Severe metabolic acidosis. You'd expect it to be, about 27.5. Is this patient overventilated? So they're intubated. So the fact that you'd have so 1.5 times bicarb plus 8, this patient potentially overventilated. The PaCO2 is that low.
I couldn't actually. I was thinking like 1.5. But I was like, I can't do maths in that case. But I know, it is low. Mm-hmm. I don't know in the exam. Do we try and do maths?
No, I don't think you need to. I just think. For these exercises, I think it's good to get your calculators out and do it. But again, I think for the exam, you just you get up to that point and go, this is how I calculate it. And then I'd check. I think you just say reasonable things that you'd be expected to do. But no examiner is going to be able to calculate that either, really.
Yeah. Cool. Thanks.
Let's take this one. 80-year-old, abdo pain, thirsty, unwell, heart rate 120, blood pressure 80 on room air. What do you think of this?
So there is adequate oxygenation with a normal AA gradient. There is an acidemia, which predominantly it's metabolic acidosis with incomplete respiratory compensation. In the context of the STEM, I would consider something like DK, but I'd like to calculate the anion gap. So I would like further information on that.
Yeah, absolutely. That's good. So I have an expected PCO2 based on that reading, but yeah, everything you said is fine. So actual PCO2 is much higher than this. So there's some kind of mixed respiratory and metabolic acidosis here as well. Good. This patient, 21-year-old with overdose of unknown medication, nausea, vomiting, and tinnitus, FI is 60%. Next person along.
Okay, so
Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.